Plasma clearance and tubular maximum. Plasma clearance is a calculated value representing the volume of plasma that is cleared of a specific substance each minute. Now, most of the time we're talking about a man-made substance, and because it's man-made, it kind of has to have specific criteria. One, it has to pass through Bowman's capsule as easily as water does, but it can't be reabsorbed and it can't be secreted. So it basically can go through step one of making urine, but then after that, if it didn't get in there in that first step, it can't go anywhere else. It can be used to estimate renal plasma flow. And if you really want more information on that, you can look in your book. Tubular load is the total amount of substance that passes through the filtration membrane into the nephron per minute. One of the things that we look at when somebody is diabetic is actually we look to see if there's glucose in there. If you have a ton of glucose in your blood, it'll end up in your urine. And that is very, very odd because normally the human body will not get rid of glucose for anything. It would be like getting rid of money for no reason. You just don't do that. Tubular maximum is the maximum rate at which a substance can be actively reabsorbed. So instead of talking about clearing something from the blood, we're talking about how fast we can reabsorb something. So urine movement. This is where things get pretty straightforward. We've just talked about in great detail the kidneys and how the kidneys work and how the workhorse of the kidney is going to be the nephron and how the nephron works and how we keep everything balanced in the kidney. Now we're going to talk about the ureters, the bladder, and the urethra, okay? The ureters are literally the tubes through which urine that has been made in my kidney flows down into my bladder. The bladder is a hollow, distendable muscular container that lies in the pelvic cavity. Basically, it holds your urine until you're ready to go, at least to a certain extent. And then the urethra, this last thing here, transports urine from your bladder to the outside of the body. Now, your ureter extends inferiorly and medially from the kidney's renal pelvis at the hilum of each kidney to reach the urinary bladder. In other words, here's the body, right? Here's my kidney. It goes toward the middle and then down from there. Goes toward the middle and then down from there. So it goes medially and then inferiorly, okay, to reach the urinary bladder. It's lined with transitional epithelium. Remember, transitional epithelium is the one where the cells slide on each other, almost like unfolding a blanket when it's folded into an accordion style. That means that it can stretch, okay? The walls consist of a lamina propria, which is a very fancy way of saying connective tissue, a smooth muscle layer, and a fibrous adventitia. The adventitia is just the connective tissue that holds it in place. It's the thing that suspends it in place and keeps it where it's supposed to be. The smooth muscle layer helps with peristaltic contractions, that milking action that we talked about in the digestive system. If we were to count on gravity to move urine from my kidney to my bladder, it would never move if I was laying down. So we actually do have to have some type of muscular contraction that contracts and pushes that urine into your bladder very intentionally. The male and the female bladder. So this is going to be the female and this is going to be the male. If you look at the male's anatomy, the bladder sits right here and the end of your colon and the rectum are back here. There's really nothing sitting directly on top of it. However, if you look at the female bladder, this is the uterus, okay? So we do have an organ sitting right on top of our bladder. And what that ultimately means is when a baby is in that uterus, it's pressing down on that bladder. Pregnant women have to go to the bathroom fairly often because their bladder is incapable of expanding because there is a baby sitting right here, right on top. And every time that baby moves, they bounce up and down on that bladder. Posteriorly to that is the actual vaginal opening for intercourse. And this is the urethra that, let me blow that up. This is the urethra that exits the bladder to empty. Here's the vaginal canal for intercourse. Here's the uterus. For a male, here's the bladder. There's nothing here. There's nothing sitting on top of it. Their urethra comes out of the penis, so it is quite a bit longer, and it actually has 2 jobs instead of just 1 because it works in their reproductive and in their urinary system, which we'll talk about in just a bit. Okay, so the ureters enter the posterior lateral surface of the urethra. It exits on the lateral surface, creating a triangle shape called the trigon. So this urethra that's coming in, hang on. This urethra that's coming in is actually coming in and kind of going back and down back here. See these 2 holes? This is where this is coming around and actually emptying into the bladder. I'm going to blow this up. If you look, here are the holes for my urethra. Here's the, ureters. Here are the holes for my ureters. Here's the exit for my urethra. Do you see this triangle shaped piece of tissue? This is what we call the trigon. Okay, the trigon. The trigon, this little area that you see right here, is less elastic than the whole rest of this bladder. Okay, and what that ultimately means is as the bladder starts to expand up, this stays. So as it starts to expand because it's filling, it actually kind of comes back and kinks the ends of these hoses so that they seal up, and hopefully what that means is you don't get any backwash. This expands this way and the bladder kind of shifts backwards and it seals these holes. Now, this works really, really well for a while, but if you hold it for too long, eventually the bladder stretches enough that these holes open back up. And if they open back up, that ultimately means that things can travel upward through this tube. If we have bacteria or something like that, they now have an open doorway to move. This is how urinary tract infections like bladder infections eventually become kidney infections, because this urethra is actually a perfect entrance for bacteria. And normally, we talked about this in chapter 22, we urinate often enough that we flush this tube and we flush this tube and we flush this tube. Well, if you're not doing that, the bacteria can basically creep their way into this space up here and start multiplying up here. And if this tube is open, they can basically start crawling their way back up into this ureter to get to the kidneys. And that's how kidney infections happen. So the bladder itself is lined with transitional epithelium. Again, you've got that kind of sliding of cells to make more space for the fluctuations in volume. Now, I'm not talking about going from like 100 cells to going to like 2 or 3. We're talking about at empty, you've got about 4 or 5 layers of cells, and at full, instead, you have 2 to 3. So it's not as dramatic as it sounds. In the middle, you've got that lamina propria. Again, it's just connective tissue. And then you've got muscle here. This is called the detrusor muscle. You know that feeling you get when you have to go to the bathroom like something is squeezing? This is the thing that's squeezing. This is the muscle that kind of squeezes and reminds you there's some fluid in here. You might need to go to the bathroom soon. The outer layer of this is, again, the adventitia, okay? So the adventitia is a connective tissue that holds things in place. So this is actually helping to suspend your bladder in the right place. When you contract the detrusor muscle in your bladder, this actually forces the urine to come out. You know that you can kind of bear down pretty hard and your urine comes out faster than if you just sit there. So the urethra, the exit. The epithelium is stratified to pseudostratified columnar epithelium. In other words, it is either one layer that looks like more than one, or it's multiple layers. It's got elastic connective tissue and smooth muscle to keep the urine from flowing out of the bladder until the pressure is great enough to force it out. So women have one sphincter. Sphincter muscle, if you'll remember, is like a drawstring on a trash bag. It seals a tube up. It seals it from, well, I guess from opening. So women have one, men have two. And that difference is actually primarily due to the fact that the male urethra does two jobs. It is the pathway for urine, for our urinary system, but it's also the pathway for semen when we're going through intercourse. So men have an internal urinary sphincter, okay? It contracts basically to prevent semen from entering the bladder during intercourse, or for urine entering the urethra when ejaculating is happening. Urine is acidic. We talked about that previously, and sperm is actually really, really pH sensitive. So if you put it in acid, it tends to die. Sealing that bladder off from the tubing to make sure there's no mixing is actually important if we're talking about reproducing the species. Again, we're talking about ourselves as animals, not as I'm a human being who has feelings, nothing like that. Just if we are pure animal, this is the way it works. Now the external, and this is also made out of smooth muscle. Okay, so smooth muscle. In other words, it is not a voluntary kind of thing. This happens in males and it is not voluntary. It's just kind of the way it works. The external urinary sphincter is actually skeletal muscle, which automatically means it is voluntary, at least to a certain extent. We have this as women, or I guess I should say I have this as a woman, and if you're a woman too, you have it. Men have it as well, and basically it surrounds the urethra and controls the urine flow. This is what either allows you to go to the bathroom when you are ready to go, or holds it when you're not ready to go. But it is a voluntarily controlled muscle. Again, for the most part, because eventually you'd pee your pants if you waited too long. As far as length goes, the urethra in males, of course, is going to be longer than females, primarily because they've got the length of the penis that they have to also take into account. Okay, so from Bowman's capsule to the renal pelvis, the gradient of hydrostatic pressure moves the filtrate or urine. Basically, it's going from the highest pressure in my glomerulus to the lower pressure in Bowman's capsule to lower pressure until it reaches the renal pelvis. Now, don't forget, the renal pelvis is that kind of collecting area in the kidney. But hydrostatic pressure in the renal pelvis is 0. Okay, so once I get there, I'm at baseline. So I actually have to push the urine into the ureters. Remember what I said about there being smooth muscle there. Those peristaltic contractions that I've been talking about are what actually forces the urine from that renal pelvis where the pressure is 0 into the bladder. Frequency of those contractions varies. It can be once every few seconds to once every 2 to 3 minutes. The parasympathetic and sympathetic nervous system will influence that frequency. If I'm in rest and digest, it'll get higher. If I'm in fight or flight, it'll get lower. As the pressure in the bladder increases, it fills. The pressure in the bladder increases as it fills. The internal pressure effectively seals the ends of the ureter. Remember what I said about I've got an empty bladder with a tube here, but as it starts to fill up, it kind of shifts backwards and it seals the end of that tube because this shifts because that trigon that's there isn't as stretchy. So it seals off the end of that tube, preventing backflow, which is why I told you guys that, going to the bathroom is so important. Now, micturition reflex. Micturition reflex. It's a very fancy way of saying peeing. The capacity of your bladder is due to 3 things. 1, the walls of your bladder are folded in the lumen in that space. And as it starts to enlarge, they basically flatten out. The wrinkles flatten out. The lining in the bladder is also transitional epithelium, meaning that it can accommodate that fluid fluctuation. As well, your bladder is made out of smooth muscle. Remember that I said there was muscle in there, the detrusor muscle? Muscle just inherently, one of the things that we talked about when we talked about muscles in, chapter 9, was that it was elastic and it was extendable, like it would stretch beyond its resting length. So, filling lifts and expands the bladder superiorly to accommodate the fluid. Stretching allows it to change, and stretching basically allows it to change by stretching without changing the pressure inside. So the pressure inside your bladder, you don't really feel that bladder filling up until it gets to about 300 milliliters. At 300 milliliters is when you kind of know, okay, my bladder's getting pretty full. The maximum volume of a bladder is about 1 liter. We start feeling discomfort, like that painful need to pee, at about half that, at about 500 milliliters. Okay, so the micturition reflex, the peeing reflex. Urine in the urinary bladder will start to stretch the bladder wall, which you can see here in this picture. Action potentials produced by the stretch receptors are carried along the pelvic nerves. So carried along these pelvic nerves, okay, to the sacral region of the spinal cord. So we're actually way down here in the sacral region at number 2. We're carrying the signal up to the sacral region. Action potentials are carried by the parasympathetic nerves, the red line here, okay, to contract the smooth muscle in the urinary bladder. So remember I told you that kind of squeezy feeling you get like when you have to pee? The ascending pathway. Remember, this isn't just going to go over here. You also have another pathway that goes up to the higher levels of your brain. So it carries an increased frequency of action potentials up the spinal cord to the pons in the cerebrum. Remember, cerebrum's the outside. When the urinary bladder becomes stretched. This basically gives you that conscious idea of, I have to go pee, I have to go to the bathroom. Now, we've got a descending pathway as well coming from our brain. So the descending pathway carries action potentials to the sacral region of the spinal cord to tonically inhibit the micturition reflex. Preventing the automatic urination when the bladder is full. Descending pathways facilitate the reflex when stretch of the urinary bladder produces the conscious urge to urinate, and this reinforces the micturition reflex. So that feeling of I have to pee goes up to your brain and you recognize that need. But if I'm standing in front of a classroom, it's not like I can just drop trowel and go, right? So I have to send a signal down and go, okay, I know I have to go, but you need to wait. And remember we talked about the external urinary sphincter. Well, that brain is going to control the external urinary sphincter with our voluntary neurons, our somatic motor, our voluntary motor neurons, basically causing it to constrict so that we don't just go. When you're a baby, you don't know what those signals mean yet. That's why babies wear diapers for as long as they do, because they don't understand what that signal means. Once we figure it out, though, then we learn, oh, I can actually hold this, and you wait until you actually have the opportunity to go. So the effects of aging. Well, in all honesty, our kidneys actually start to decrease in size. And one of the reasons that is because we have a decrease in the blood flow to our kidneys as time goes on. The number of functional nephrons also decreases. So the number of nephrons that actually work are starting to go down. Renin secretion and vitamin D synthesis decrease. The nephron's ability to secrete and absorb also declines. So again, everything goes downhill as we age. But remember something. Yes, we're losing quite a bit of function here, but we only need 1/3 of one kidney to work to give us enough function for us to be able to survive. So we could lose an entire kidney and be perfectly fine. That's why people can actually donate one kidney to somebody and keep a kidney and they're fine, because we don't need 2 whole kidneys. It's a great backup system, but we don't necessarily need it. So if we have functional nephrons decreasing, we still have some that work, so we're okay. Renin secretion and vitamin D synthesis decreases, yes, but we still have it. It's not completely gone. So yeah, and that is the end of chapter 26.